So why don't you tell me a little bit about yourself and how you got interested in the health industry?
Well, so I have a geek by training, so I have a computer science degree, and then I went back into my master's in technology management. So I've got one foot in both doors, so I can talk to business people about the business side and technology people because I still code for a living and architect and engineer systems. Back in the late 90s, I was interested in the healthcare field because I got a job as an architect at the American Red Cross, where we built one of the nation's largest electronic health record solutions, which manages probably 12 to 15 million patient records at any given time. Pretty much anybody that gives blood in the country through the American Red Cross goes through that system that I helped architect. So when I got in that environment, I was happy that I could use my technology skills specifically in healthcare because it's something that at the end of the day, in other industries like if you're working in entertainment or finance or whatever, you come back at the end of the day and say, what did I accomplish? In healthcare and technology, you never wonder that. You're always going to accomplish something useful in the healthcare universe. So that's really what brought me the interest. And of course, I've been an architect and engineer. I've built dozens of products in my life, many of them in healthcare. So that's where my interest lies, really.
Okay. So what do you see the future as for health technology? Where do you see a lot of the innovation coming from and areas and things like that?
I say the biggest areas for innovation are in micro, small-ish type of software and packages that will be tied to medical devices that are going to be integration friendly. And what that basically means is that a lot of observations that physicians do about us, taking our temperature, weight, and other measurements, lab tests that we perform, genetic marker evaluations that we do, these things are going to become extremely cheap and very easy to get at in comparison to where they are today. And what will happen is that a physician's diagnostic assistant is likely to be the next big innovation, where these tools, the physicians that start using these diagnostic assistance tools, are going to end up being just much better than their counterparts that don't use them. So just like today, if a physician, will put his hand on your forehead to measure your temperature instead of sticking something in your mouth and being able to using, an electronic measurement tool for temperature, would be silly in a few years. Someone who does not who is not able to run the lab test, do imaging analysis, who can do advanced diagnostic tests through using technology such as microfluidics and other things, is just going to be esoteric and is not going to have a whole lot of patients going to him anymore. So that what we need is, we don't need another iPhone app, we don't need another mobile app to capture data from a human being. I don't want to have to type something in. We need apps, technologies, medical devices, etc., to use sensors around them, and sensors that are built into these mobile devices and others to capture this data, but more importantly, do it in a way that is very integration friendly. So we have many new devices that are coming out these days that are not integration friendly. They take a measurement and then it sits there on the device. So devices are important, genetic markers and other tests are important, etc. And what we're going to see is more and more sophistication of these devices, but even more important will be the integration side, which is going to buy us data analytics and other things which we can't even fathom today. There's going to be so many cool things that once sensors are picking up a lot of data and dropping them into our records, we will be able to do scans and analysis in a way that we just not fully realized.
Mm-hmm. So you're saying that it's going to be more of like a sensor type based devices where you can put like maybe a patch on yourself someplace and it just automatically monitors and uploads that data up to like the cloud or something like that?
That's right. From a diagnostic point of view, remember that in the healthcare world, when you look at technology, it falls into 4 or 5 big blocks. One
Okay. So what do you think is kind of like maybe the time frame when all this is going to happen? I know a lot of it's happening now, but in what kind of time frame do you think that that we're going to see a lot of this innovation?
I'm guessing that as the Affordable Care Act moves forward from a fee-for-service or volume-based plan, payment plan to a value-based, kind of like an accountable care, patient-centered medical home, where the outcome matters more than the service that you perform, then we will see advanced technology coming in. One of the reasons why advanced technology in healthcare doesn't really matter in many cases is because physicians and hospitals get paid for services that they perform, not the outcomes that they achieve. In other businesses, we're not paid for services, we pay for outcomes that are achieved. And so what we see is that value-based purchasing instead of volume-based purchasing is definitely making the move. So, the Affordable Care Act is starting to put a lot of payment models into place. And if those payment models start to work and outcomes become more important to see, then we're going to see these kinds of smaller, more useful, diagnosis-friendly, therapeutic-friendly kinds of devices come in and become that much more useful. And devices don't have to be physical medical devices. They could be software running on mobile apps. I think software running on mobile phones as mobile apps for specific devices. But ultimately, it all depends on how reimbursement will occur, et cetera. Like today, for example, the more MRIs you do on someone, the more you get paid.
Mm-hmm.
So it doesn't help for you to have a small, cheap machine. What you want is large, expensive machines because you want to charge a lot for these kinds of devices. Until the payment models change and are in effect promoting and incenting small, nimble technologies to be put into place so that they help maintain and improve our health as opposed to simply get paid for services around it. Then we'll see these kind of more unique innovations taking off.
Okay. So, is there anything else you'd like to say about health technology?
Yeah, I would say that one of the areas that we should be pushing on all of our technologies, anything related to electronic kinds of data capture, et cetera, should be done in as integration-friendly a manner as possible. And that means that if you don't create a new application unless you're ready to create a way to take that data and easily export it, create an API around it, allow it to be integrated and pushed into electronic health record solutions. Now, a lot of vendors will say, well, electronic health records are ready to pull them in, et cetera, but that's only going to be a short-term problem. Over the next couple of years, we're going to see electronic health record solutions be able to pull this kind of data in, but then the problem will be that not enough devices are promoted. So what we need to do is, since a lot of what you're trying to produce is guidance to others on what to build, you want to make sure that you're very, very integration friendly. And so on Monday, my talk that I'm doing, I think it's at 11 o'clock, is specifically talking about the myth of health data complexity. And so you can talk about that if they're going to be there and are going to be at the conference. You can certainly count after that to talk about any questions you might have around that. But it talks about 5 or 6 techniques for how people can use the integration-friendly techniques to create better health technology.
Mm-hmm. Yeah, I had a discussion with a board of director from one of the local hospitals here last week, El Camino Hospital, and he was kind of saying the same thing. But he approached it from a different angle. He said there's no standards really for the medical records. and we needed to come up with a standard. So when he said that, I was like thinking to myself, well, it's I guess most like maybe like databases. So like there's all different types of databases out there and all different types of proprietary information on the databases as far as file handling. But you can always export out to a CSV file and then import that into another type of database.
Yeah, it's a common misconception, and a lot of people who don't know enough about the technology say that. It's just not true that there are no standards. Every standard that you need to do a bare bones health integration, it already exists and has existed for over a decade.
Mm-hmm.
And now it's required that we use as well. So we have HL7, we have Blue Button, we have CDA, we have PCR. The technologies and the standards both exist. They need human beings to start standing up and saying, I will use them. I will force my vendors to use them. So if you, next time you talk to a director of a hospital, you say to them and say, how many times have you spoken to your vendor and said, if you don't give me interoperable health records, I will stop buying from you? Very few of them do that. In our other industries, when someone doesn't give us something that can export data, we don't buy from them. But in the healthcare world, often the health and topo by our respective vendors, the larger EHR vendors, etc., hold hospital hostage, and hold their data hostage, basically, because they are given the choice to do so. That contract has been signed. There are many people within hospital environments that don't understand that the technology is there. The EHR vendor does not want healthcare data interoperability. If they got healthcare interoperability, it reduces the power of an EHR to be as threatening and hold and so hold and hold hostage data that's sitting inside the hospital. So it's absolutely a misconception that the standards don't exist. It is a myth that the data is so complex that it can't be shared, etc. We have the basics of the need. We just don't have courage in our technicians, courage in our senior technology management, etc., to force vendors to be interoperable.
Yeah, interesting. So is there anything else you'd like to say?
I would say the last piece would be to give some thought to figuring out an approach. And as they're starting to do some interviews and stuff like that, see if you can figure out an approach for how some smaller vendors who they have a really good idea, they've done their basic analysis, will work, etc., could find proper pilot sites. So, when you're talking with these customers, if you're going to do some interviews, ask questions to some of them that say, would you be willing to be a pilot site for an innovative technology? If so, how does the startup reach you and talk to you about it being a pilot site?
Mm-hmm. Okay. Yeah, that's an interesting idea. Yeah, thank you.